Hi class, this lecture is going to talk about gestational diabetes. You should have these PowerPoint slides located in Canvas. Hopefully you've printed them off and are following along and taking notes. Please write down any questions that you may have. You can email me or we can discuss it next time we meet in person. Okay, so like a lot of things that we've been learning in OB, the LPN is not allowed to care for patients who are high risk. However, we need to know a lot of the things that we're learning so that we can alert the RN or the provider and going on, and also educate our clients about what's happening. Okay, so from your diabetes lecture, you guys should remember that insulin allows cells to take in glucose for energy, and it's produced by beta cells in the pancreas. You remember that type 1 diabetes is defined as insulin deficiency, so that means that the pancreas is not producing enough insulin, or any insulin maybe, about 5% of diabetics. For type 2 diabetes, that is insulin resistance. So the pancreas is producing insulin, but the cells aren't able to take in the insulin. That's type 2. Gestational diabetes is defined as glucose intolerance. It's happening because of hormones in the placenta. Could be because we're not producing enough insulin, and also that the cells aren't taking in enough insulin. So it could be both type 1 and type 2. We're just not quite sure, so we call it glucose intolerance. There are two types of gestational diabetes. We have pre-gestational diabetes, which is our type 1 and type 2 diabetes. This is identified before conception and is an alteration in carbohydrate metabolism. Gestational diabetes develops during pregnancy, and it's usually around the 24th week of pregnancy. It affects up to 10% of pregnancies. That's quite a bit, and we're just not sure who is going to get it or not. So we screen every patient every time, every visit for glucose in their urine, and then later on in pregnancy, we'll do that glucose tolerance test. Normal pregnancy, as the baby starts to develop and get closer to delivery, the placenta will start to secrete diabetogenic hormones called the human placental lactogen, or HPL, and growth hormone along with progesterone. These hormones cause insulin resistance in the mother purposefully to increase her glucose levels and make the baby grow and mature to be ready to be delivered. As it grows, it puts on extra fat stores so that it can help regulate its temperature outside the womb. So that's why it does it purposefully. The insulin resistance will peak in the last trimester to finally fatten up the baby. Diabetes and pregnancy, when we talk about glucose intolerance, we're talking about, like I said in the last slide, insufficient insulin or insulin resistance. We're just really not sure. It's causing hyperglycemia in the mother. Patients with gestational diabetes can't cope with the placental metabolic changes that are going on, and therefore they can't break down that glucose. So more glucose than we wanted is going to the baby, which makes our babies a lot bigger and can cause lots of problems for our babies. So when we're thinking about normally when we increase those hormones to cause insulin resistance, how do we think that would affect our pre-gestational diabetic patients, type 1 and type 2 diabetics? Give you a second to think about it. And if you thought that it would affect them by making them have to increase their insulin, you are correct. They're going to have to increase their medications and insulin to combat that hyperglycemia. And it's gestational diabetes, excuse me, women over 25. Women who have had previous gestational diabetes. If they've had a previous large for gestational age baby without gestational diabetes diagnosis, if they're overweight or obese, if they have a family history of diabetes, and then, of course, certain cultural groups with high incidence of diabetes, as in our Native Americans, Asian Americans, and Pacific Islanders. From a previous lecture, you should have learned about glucose testing. We do it between 24 and 28 weeks of gestational age. We test all women because we don't know who's going to get gestational diabetes and who isn't, unless they're high risk, right? If they're high risk, we're going to do this glucose tolerance test at the beginning of the pregnancy, at the first prenatal visit. And then every visit, every time, no matter what, is going to get a urine dip for glucose. And then when we do that first screening between 24 and 28 weeks gestation, we will do the 1 hour glucose tolerance test, where the mother will drink a 75-gram glucose drink. They can be fasting or non-fasting, and then we measure their glucose an hour after the glucose is given. If it's greater than 140, it is abnormal, and therefore the provider will order a repeat test, but this time it's going to be a 3-hour glucose tolerance test. Now, different labs may use different grams for their oral drinks, but this is what your text says. So if abnormal, the 3-hour glucose tolerance test, the drink is going to be a 100-gram glucose drink. This is going to start, we're going to start drawing blood with a fasting result. Normal will be less than 92. And then they'll drink the drink. Once the drink is finished, we will test their blood at 1 hour. Normal is less than 180. Then 2 hours, normal is less than 153. And then 3 hours, normal is less than 140. If 2 of those 4 tests end up being abnormal, then you get a diagnosis of gestational diabetes. So 2 of those results have to be abnormal in the 3-hour glucose tolerance test in order to be defined as gestational diabetes. Now, if one of them was abnormal, we would still monitor closely and encourage diet and exercise for that mother. Cues are the same as cues for type 1 and type 2. We have polyphagia, constant hunger, constant hunger, polydipsia, excessive thirst, polyuria, voiding all the time, and of course sugar in the urine. What happens to mom? We have frequent urinary tract infections because of the increased glucose in the urine, yeast infections related to the hyperglycemia. We can have a risk for preterm labor because that uterus will get overstretched from a lot of fluid, amniotic fluid, and so the uterus will think that maybe it's getting close to term, and maybe the membranes will rupture early, water will break early. Ketoacidosis, of course, for all diabetics related to uncontrolled hyperglycemia. Gestational hypertension, so high blood pressure, causes unknown. Hydramnios, specifically polyhydramnios, which is excess amniotic fluid. That's due to the baby getting symptoms of hyperglycemia. So they're drinking their amniotic fluid and peeing and drinking and peeing, causing extra amniotic fluid related to the hyperglycemia. Stillbirth can be a complication from ketoacidosis and poor glucose control. And mothers who have gestational diabetes have a 50% risk of type 2 diabetes later in life. Effects on the baby. There are several effects. I actually have 2 slides for this one. We can have a cord prolapse where the umbilical cord can get pinched when the water breaks related to excessive amniotic fluid or polyhydramnios. We can have congenital anomalies if we have hyperglycemia in the first trimester, cardiac anomalies, neural tube defects, skeletal deformities, and genitourinary problems. Again, those are if we have hyperglycemia in the first trimester when the fetus is developing. You can have macrosomia. That means a large baby in utero and related to the hyperglycemia. And then once the baby's born, it's called LGA, large for gestational age. So in the womb, if we have a large baby, it's called macrosomia. And then once the baby is birthed, it's called large for gestational age, or LGA. We can have birth trauma related to the increased size of the fetus, so baby might get stuck on the way out, either with a C-section or with a vaginal delivery. Term birth related to the polyhydramnios, overstretching of the uterus, and aging placenta. Fetal asphyxia secondary to hyperglycemia and hyperinsulinemia. And then rarely we have intrauterine growth restriction, so IUGR. That is a small baby in utero, converse of the macrosomia, right? So a small baby in utero is intrauterine growth restriction. Once the baby is born, then that's small for gestational age, or SGA. And that's related to vascular impairment. Maybe we had hypertension in pregnancy, or gestational hypertension caused by the gestational diabetes, which decreases placental perfusion to the fetus. Effects on baby: perinatal death due to poor placental perfusion and hypoxia. Respiratory distress syndrome. They have poor surfactant production, making their lungs mature slower than babies without gestational diabetes, or the mamas without gestational diabetes. And polycythemia, excessive red blood cells in response to hypoxia. So babies aren't getting enough oxygen through the placenta. They're going to make more red blood cells, which is called polycythemia. And then once they're born, they can have hyperbilirubinemia, causing jaundice, which is excessive red blood cell breakdown from the increased red blood cells from the hypoxia, and an immature liver that can't break down those blood cells. You can have neonatal hypoglycemia related to the pancreas being used to having increased glucose levels, so it's spitting off insulin, because it's used to that steady, constant flow of glucose, which is too much glucose. And once the baby's born and the placenta is delivered, it's not giving it that steady flow of glucose. And the pancreas doesn't know that it's not going to have it, so it just keeps giving insulin, and then our babies can crash and become hypoglycemic very quickly. So we need to encourage quick feeding right after birth and frequent feedings to prevent hypoglycemia in the newborn. And then when they grow up, they can have childhood obesity and they're at higher risk for diabetes in later on in life. We manage it. Our goal is to maintain blood sugar levels in the mom. Fasting less than 95 is what we want. Less than 140, 1 hour PP. PP stands for postprandial, which means after meals. So we want less than 140 blood sugar 1 hour after meals, and then less than 120 blood sugar 2 hours postprandial, and a hemoglobin A1C of less than 7%. That's going to give us our best case scenario for our fetus to be born. We need to avoid both hyper and hypoglycemia, just like regular diabetics. Our number one treatment of choice for gestational diabetes is first, we're going to do diet and exercise. If diet and exercise doesn't work, then our drug of choice is insulin. Insulin does not cross the placenta. It's intermediate and it's short acting. We give it twice daily, and again, it is the medication of choice. Now, in recent years, we've been introducing glyburide and metformin, which seems to have some effect on hyperglycemia. However, it is not the medication of choice. Insulin is, which we would give twice daily. And again, glyburide and metformin do not cross the placenta either. However, insulin works better. Because we have all of those risks to the fetus, we're going to do frequent fetal surveillance, making sure our baby is doing okay. We're going to monitor for congenital anomalies in that first trimester and moving on. We're going to do frequent ultrasounds for estimated fetal weight to make sure the baby's not growing too big, or look for that fetal macrosomia, too big, too large of a fetus. We're going to do non-stress tests every 2 weeks, and then every 1 week if they're higher risk. That's where we put the baby on the monitor and we're looking for those 2 accelerations in 20 minutes. Once we hit 2 accelerations in 20 minutes and moderate variability, we know that baby is doing well. We can take them off the monitor. We'll also do those biophysical profiles that we learned earlier on in our other lectures. And as long as all of that looks okay, we can continue with the pregnancy. Intrapartum care. So once the mom is in labor, actually any mom in labor their body is going through a very stressful period, right? And you guys should know from other classes that our liver stores glucose for stressful periods. And so moms will produce or release more glucose in labor related to all of the effort that the body is trying to do to birth the baby. And so if we're going to monitor her blood sugars very closely, we're going to check them every 1 to 2 hours, and we want to keep that glucose below 110. I know that seems kind of low, right? Not low, but on the lower end. But that's because we don't want baby to have a lot of glucose right when it's born, so that we can prevent that hypoglycemia from happening rapidly. So if mom's glucose is above 110, we may need to initiate an insulin drip to keep those levels down during labor. Our fluids of choice will be either lactated ringers or normal saline, depending on what the provider writes for. To make up another point, even if mom is NPO during labor or not taking in fluids or food, the liver will still push glucose to the body, and so even if they're not eating, their sugars may be increased. Care of the postpartum woman and neonatal care. For the mom, gestational diabetes typically resolves after the placenta is delivered. However, we're still going to monitor her for hypoglycemia and for type 2 diabetes because she's at higher risk in the future. Our type 1 diabetics will return to our pre-pregnant insulin management that they were doing before. In the baby, we're looking for hypoglycemia. They're at risk for hypoglycemia related to that pancreas spitting off lots of insulin. And so that will drop their sugar very quickly. So we're going to encourage early feeding and monitor the glucose levels very closely. Once the patient is diagnosed with gestational diabetes, we need to educate her. Because both mom and baby is at high risk for a lot of things to happen, we're going to encourage her to keep her prenatal appointments, monitor her blood glucose as directed, perform those daily fetal kick counts. If you remember, kick counts are done once a day. Lay on your side, drink a large glass of cold water or juice, and then they need to count. We need at least 10 kicks or movements, doesn't have to be a big kick, in 2 hours. Once they get to 10, they can stop. If they don't get to 10 in 2 hours, they need to come in immediately. We're going to have them drink 8 to 10 glasses of water a day. If they drink caffeine, they need to add water to that. Wear proper footwear to prevent injury, just like our regular diabetics. Exercise regularly and avoid extreme temperatures. And then consider breastfeeding to lower blood glucose levels. Additionally, if they're taking insulin, administer the correct dose at the correct time, of course. Eat breakfast within 30 minutes of giving insulin. Plan meals and snacks throughout the day. And just like other diabetics, avoid simple sugars, candy, cake, and cookies. Because simple sugars spike the blood sugar very quickly and also lower the blood sugar very quickly. No signs and symptoms of hypo and hyperglycemia and their treatments. You should wear a diabetic identification bracelet, wash their hands frequently to prevent infection, and report all signs and symptoms of illness, infection, or dehydration. Here's a cute little picture of a little chubby baby. Just thought it was cute, and it kind of goes with our large for gestational age babies, right? But that's a pretty old little baby, probably like 6 or 7 months old there. I hope you enjoyed this lecture. If you have any questions, of course, please feel free to email me or let me know in our when we see each other next. Have a great day.